Everyone, so today I am going to continue about the last presentation which Komal has taken for the pathophysiology and the introduction for the SOJIA case. So today we are going to discuss about the treatment part of it. So first thing is like after that diagnosis we'll go for the testing for the SOJIA, right? So in the after diagnosis, in the testing part, first we take about the health history. So if you remember about that diagnosis, it was written like the fever should be continuous with the high grade for the 2 weeks, and the joint pain or the inflammation should be in the multiple joint, and that should last more than 6 weeks. So for that point of view, the health history is taken by the doctor or the physician which is going to diagnose. For here we take the health history to learn about the past illness and the current medication, as well as the detail of the current of the symptoms, such as how long the child had that symptoms and all. So after that we also see the length, because in both the factor what the fever and the joint pain was there the time duration was mentioned. Fever should be last more than 4 weeks and the joint pain should last more than 6 weeks. So the time duration is also important in these symptoms. So that also comes under the health history. Next is physical examination. So for here we look for the tenderness, warmth, swelling and redness of the and the range of motion, especially of the joints which are like affected or the one which has come into the now especially for the knee, wrist, ankle and hip joint is the most affected in this disease. And apart from that, jaw and neck are also like the patient will have the stiffness in the neck and they will not be able to move. After that, the joint inflammation, like if the joint is affected in the patient, they will like the bone growth is retarded in that chronic inflammation will retard the growthness of the bone, because of which there will be like limbs of the limb length and the overall growth of the child is also measured. So if we can take like if the child is affected with the one leg, so let us suppose like right leg is affected with the SOJIA, then the growth of that in the right leg will be less. So from there we can see like the left leg will be like normally grown, but the right leg will be like less growth. From there we can say that uneven growing is there, and overall growth factor like if the patient is affected in the spine and the hip bones or the longer bones, then overall growth is also retarded in the patient. So for that overall growth ratio is also taken out by the physician, and for that a Z score is the one formula is there on the basis of the height, weight and the length of the limbs. That Z score is measured. It is like a WHO recommended for the SOJIA cases where the overall growth of the patient is determined. Now other tests like imagining test we have like X-ray, CT, MRI. Then after discogram is like we measure about the spine disc. If the spine is affected in the SOJIA, the discogram is done to measure the disc, that gap between the two spinal. Then other like orthography, low body nerve evaluation, muscle strength evaluation, then static nerve test, nerve conduction studies. These are the other imaging test which is done for the case of SOJIA. So after that we have some laboratory finding, like most of the laboratory finding what we do is like not very important, but some markers are there, biomarkers which we call like sedimentation, erythropoietic sedimentation rate and CRP. Then after ferritin, iron absorption, platelet count and WBC count. These are the some markers which helps out to figure out the condition or the status of the disease, like how badly it has affected to the patient. So another is like anti-nuclear antibodies or the rheumatoid factor antibodies. That is not found in the SOJIA, because in the last discussion it was clear that it is not an autoimmune disease, it is auto-inflammatory disease. So because of that, anti-nuclear antibodies or rheumatoid factor are not found in these cases. So apart from other, like we do the LFT also, triglyceride or the fibrogen level also it is checked in some cases. Now coming to the treatment, we have like the first NSAIDs are there, first choice of the drugs. If like initially when the disease is diagnosed, at the first choice of drug will be the NSAID. In that we have the naproxen, indomethacin and ibuprofen. So the doses for naproxen is the 10 to 20 mg per kg per day, and the doses will be like BD, and the maximum dose can be given is 1 gram. In indomethacin, the doses will be 1.5 to 3 mg per kg per day, and then the dose will be like thrice a day, and then after maximum dose is 150 mg. Then ibuprofen is like 30 to 40 mg per kg per day, and the doses go for like a thrice or 4 times a day, and then after 2.4 gram is the maximum dose we can give. So once this, if the patient is not so responsive or the significant improvement is not seen in the patient, then they will go for the DMA or DS choice of drugs. In that we have like a methotrexate, sulfasalazine and the leflunomide. So here we can see the doses and the route of administration. Like the doses for methotrexate is 10 to 15 mg per meter square, that is calculated on the base of body surface area. Like it's given once weekly, orally prefer an empty stomach, and subcutaneous route also given, and it is administered with the folic acid and the folinic acid too. That folic acid or the folinic acid is given because to decrease the ADR of like a side effect of methotrexate, which is having like a deadly what you call side effect like hepatotoxicity, bone marrow suppression and other. So to decrease that ADR, it is given with the folic acid or the folinic acid. So the administration like giving the folic acid and folinic acid can also be like if methotrexate is given once weekly, right? So either we can give this folic acid 1 mg every day or 5 mg once weekly also. So these two choices are there with the doctors, like what they want to prefer. So clinically monitor like the methotrexate cycle goes for 6 to 12 weeks minimum. After that, the initial evaluation or the first evaluation is done once the methotrexate is started, and for that the CBC with WBC count, differential count and platelet MCV liver function test are done initially for first 4 to 8 weeks. Then after accordingly the disease status, like if it has improved or not, the duration or the dosage adjustment is done. So same like sulfasalazine, we have 30 to 50 mg per kg per day divided into 2 doses, maximum 2 gram per day. So improvement seen over here is 4 to 8 weeks. Initial evaluation is done in 2 to 4 weeks, and then every after 2 to 4 months, and if discontinue, if the rashes comes. So next we have the leflunomide. It is given on the basis of the weight. If the weight of a child is less than 20 kg, so 10 mg is given every other day, and if the above 28 to 40 kg, it is given 10 mg per day daily, and more than 40 kg 20 mg daily is given. So in this all we have like the same ADR what we find in this all 3 drugs. That's why all the laboratory monitoring should be done after like once the dose is initiated, after the fixed date or the time of period, the evaluation is to be done. Now this third line of drug is biological DMRDS. We have like Etanercept, infliximab and the adalimumab. So these are the drugs which comes in the combination like So these are the drugs which are like a TNF, like tumor necrosis factor inhibitor or the soluble receptor. These are the one which deals with the TNF, which is one of the most like a factor which is responsible for the inflammation in the arthritis. So firstly with the Etanercept is the one Etanercept is the one which is taken as the first line. Once the patient is doing great with that, other 2 drugs are not taken. But if the Etanercept, the patient is not having a significant improvement with that the first drug, the other 2 like infliximab and the adalimumab is taken in the prescription. Then after we have like then we have like Abatacept is the one that is called T cell co-stimulation inhibitors. Like we know that the T cell need 2 stimulation, like it get activated into 2 phase. So because of the CD80 and CD40 proteins, and because of that, this abatacept is the one which inhibit the CD cells and inhibit the activation or the stimulation of T cells. And the dose for this is like 10 mg per kg. Maximum is 1 gram administered intravenously at the 0 to 4 weeks and every 4 weeks thereafter. So another line we have like anakinra, then rilonacept and the canakinumab. These are the interleukins inhibitors. They are like the most commonly used is like anakinra drugs, like the one which is having a less ADR. If the patient is not tolerable or the significant improvement is not seen, then they get switched off to the rilonacept and the canakinumab. Another we have like tocilizumab. This is the interleukin 6 receptor antibody inhibitor, and another is the rituximab. So this is the CD20 antibody inhibitors. Another we have like a thalidomide in the SHEKHAR patient. Like this is the also drug which is most commonly nowadays has been used. It is like belong to the class angiogenesis inhibitor and the neoplastic also. The dose over here it is taken in the SHEKHAR case is 3 to 5 mg per kg per day, and it is the immunomodulator agent, the one which like inhibit the inflammatory factors like tumor necrosis factor alpha and other the interleukin sins. The efficacy is assessed using the juvenile arthritis disease activity score, JADAS. So this JADAS is the standard form of evaluating the improvement in the patient. They have like the scale from 0 to 10, and different factor they consider in that is like erythrocyte sedimentation rate, CRP, the movement of the like body and the movement in the patient, like a range of mobility in the patient, and then after the joints, like how many joints has been affected in it. So on the basis of that they do the scoring. And the adverse effect of this thalidomide is sedation, somnolence, myalgia, constipation, neutropenia and anaphylaxis. Peripheral neuropathy is also observed for the long-term use of this drug. So this is the monograph or the flow chart algorithm for how the choice of the drug is made when the patient is diagnosed with the SOJIA. So firstly, the NSAID with the corticosteroids are implemented. Once after 1 month, if the patient is not giving a significant improvement, then they will go to the methotrexate, that is our synthetic DMRDS, and after that 3 months it is continued, and once the patient is not showing any improvement, then they will go for the synthetic DMRDS, the biological DMRDS, that is called targeted therapy, that TNF blockers, interleukins blockers and other. Apart from the drug therapy, some like a non-drug or the exercise also is implemented for the patient. Like the first most condition over here is like the symptoms should be controlled, like the patient should be able to do the exercise. If that person, the patient is like able to move their body or go for the physical therapy, then exercise and other things are also implemented by the physical therapist in this, so to maintain the joint functions and the flexibility. These are the source of information for both like last class pathophysiology and this treatment.